For millions of people around the world, perhaps the biggest question at the moment is on when there will be a cure for COVID. There are excellent vaccine candidates around the world which are being developed, some peer-reviewed, some still in the works, and some which perhaps need a greater deal of international verification. The latest vaccine is from Russia, the first one to be released by a nation. President Vladimir Putin says he's even inoculated his own daughter. Is it safe? Does it give us hope? Joining us now, Dr. David Nabarro, the World Health Organization's Special Envoy for COVID-19. Dr. Nabarro, pleasure speaking to you.
Hello, how do you do?
The vaccine from Russia, do you have confidence in it working?
Well, it's really good news to hear that there's another candidate vaccine that's available. I have to share with everybody the way in which vaccines work. What it is that you take some derivative of the virus that is causing the disease, but it is in fact in itself harmless, and you inject it into people so that they can build up their own defenses. And so if they're exposed to the virus, they are protected against it. It's a beautiful system when it works. And the reason why there are many different candidates for vaccines is that different laboratories around the world have established different compounds. And the Russian compound that's being described sounds, as I say, very promising. But there is a succession of tests that each vaccine candidate has to go through. They're called phase 1, phase 2, phase 3 trials. And the Russian candidate is in the process of going through its phase 3 trials. Let's hope that it comes out with all the different indices suggesting that it is effective and it is safe. Russia has already indicated that it's going to be used within their country. The question is, will it also be going through all the different tests that are necessary for it to be perhaps made available to other countries? And I'm very hopeful that along with other candidates that are coming along, we're getting a good pathway, a good pipeline of candidates coming through.
Dr. Nabarro, does the WHO have concerns so far on the Russian vaccine? Have they cut corners?
At the moment, we're just in WHO waiting for the information. What happens is that countries supply the data to WHO for what's called the pre-qualification process that can then lead to a vaccine being taken on and made available more widely. And the Russian authorities who produced other vaccines, for example, on yellow fever, know what's involved, and in due course they'll supply those data and then we'll be able to see. Absolutely no concerns, just looking forward to receiving the information, along with information about other vaccines that are under development.
Dr. Nabarro, phase 3 trials are on presently as far as the Oxford vaccine candidate is concerned. There's also been a lot of peer review as far as the Wuhan vaccine candidate is concerned. Now, that was news that we actually got a couple of weeks back when Lancet came out with its publications. In the last few weeks, is there anything new to suggest that these two vaccine candidates are headed in the right direction?
Well, there's quite a number of candidates coming through what we call the phase 2 trials, which are trials on volunteers and in groups of volunteers. But the phase 3 trials are altogether more complex because they involve testing the vaccine in populations that are exposed to the disease in multiple settings around the world. You've mentioned that there's a candidate vaccine that's come from China. There's another candidate vaccine being talked about that's come from Oxford with a commercial collaborator. There's a candidate vaccine coming from the east coast of the US, again with a combination of a company and other researchers. Let's look at it. We've probably got 3 or 4 vaccines going into the phase 3 trials, and we're anticipating that it'll be a bit of time before we've got all the data coming through. And I'm continuing to say to people who ask me, we have to recognize that for the time being, we don't have a vaccine. So we all need to work hard on the work needed now to make sure that societies everywhere are able to keep going with the constant threat of COVID. And then when the vaccine does come, then we will have an additional wonderful new asset to help us with our defence, and I hope that we will then be able to offer people all over the world the potential for protection through a vaccine.
How important is it to take into account genetic variations in phase 3 trials? Even in the case of the Oxford vaccine, though there were tests on people of different races, there were perhaps not that large a number of variations which were looked at. Therefore, is there a real concern at the WHO that unless you test more, genetic variations could play a factor in how effectively it affects different people?
Well, thank you very much for bringing this point out. You start with your candidate vaccine, you test it on volunteers, you then test it on a wider population, then you test it on lots of different communities around the world. That's what the design of a phase 3 trial is meant for, to look exactly at what you've just said. Differences between ethnic groups, differences between racial groups, precisely because there's always a chance that different groups of people will react in their own way to a vaccine. I think that there is a well-developed series of protocols for vaccine assessment. They're actually available on the internet, at the WHO website, and anybody who wants to can see what these protocols are. And the reason why this is important is that we do have communities in the world today who are quite nervous about vaccines and are not sure that they're ready to accept being vaccinated against any disease. And so the World Health Organization is trying to help the public understand that there are clear protocols for assessing both efficacy, whether it works, and safety, whether it has side effects. And if we can make sure that everybody knows that WHO is acting on behalf of the world population in trying to make sure that all vaccines are put through the tests to their full extent, then I hope that this will reassure people.
So, Dr. Nabarro, a lot of our viewers
Yes,
would be asking one question or making one comment. Oh, look, this is all very well, but what we need to know is when are we going to get inoculated at this pace? It's a valid question, and I understand the need for caution. I mean, absolutely. That said, when here in India or anywhere in the world for that matter, will you give us a realistic time frame? Or can you give us one now?
Thank you very much indeed. And I have been asked this question quite a lot, and I so understand how important it is. We have a world that is in many places a bit kind of stuck while leaders work out how they're going to get ahead of this virus, whilst at the same time getting the economies and social life going again. It's terribly important. So yes, we need a date. Now, I've said to many people that in my experience of working with vaccine development, especially when we've got a new virus that we're trying to deal with, it's important to recognise that this does take time. And so I've said that it could be 2 or 2.5 years before everybody in the world has an opportunity of being immunised with a vaccine that works and that is widely available. I'm sticking to that quite long time frame because, as far as I'm concerned, it's not terribly helpful to the world if a small population in a particular location can have access to the vaccine because their government can afford to buy it. I'm interested in the moment when everybody in the world, regardless of where they live or regardless of how wealthy they are, can get an opportunity to be protected, and protected in a way that's safe and that works. So I do think that we need to be thinking in terms of a number of years, and I'm saying possibly 2 years. However, I'm also hopeful that things can be speeded up without cutting any corners. I'm watching an immense amount of technical activity, plus political activity as well, by different governments saying, we want to make sure that we've got a system for enabling everybody to have access. So I'm hopeful that we can get it quicker than 2 years, but I don't really want to give you an actual date, because if I'm wrong, then people will just turn around and say he raised expectations. So I'm not going to say whether it's months or years. I'm just going to say that in my own judgment, we should really be reckoning on 2 years and hopeful that it can get quicker.
So 2 years before it actually comes into manufacture, it's widely available, or 2 years before you expect a large number of people to have been inoculated?
That's it. It's the second point,
right.
Vishnu. And the reason for that is that I was very much involved in a number of immunisation campaigns around the world, and I know how incredibly difficult they are to organise. We're still trying to immunise everybody against polio and to get that disease eradicated. We're still in the process of trying to make sure that every child can be immunised against measles. And we've had some reversals there. And then there are other vaccines that have become available against meningitis and so on. And so I've seen with my own eyes that it's not a simple process of immunising everybody. Even if we go back to smallpox, one of the great success stories of immunisation, it required enormous international collaboration, and it did take quite a long time to get it done. And that's why I'm giving this longer time scale, because my focus is on when can everybody expect to be immunised, and I'm saying 2 years, but let's try to make it quicker.
Okay. Now, we've got the Serum Institute of India, which has huge manufacturing capability. They've tied up with the Oxford vaccine candidate, and they are building up capacity at a massive stage, and they're quite willing to accept that if that doesn't work, then their investment goes down the tubes quite literally. It will be destroyed, the stock. It's a risk they're willing to take. But is this something that you welcome, that assuming this candidate, which has been widely reviewed to be quite good so far being the key word, then we would be in a position to have millions of doses ready at a time when the WHO says, look, it's time to go ahead and start inoculating?
Yes. Well, I think it's amazing. You know, sometimes we lament that international cooperation around the COVID has been a bit patchy. But when I hear that the Serum Institute has decided to invest capacity so that a candidate vaccine could be taken to scale, I am overjoyed. It shows a willingness on the part of this wonderful Indian institution to put the needs of the world's population first. And I absolutely admire it. And I'm hearing of other similar examples with others of the candidate vaccines are coming on board, of companies receiving money from governments and being able to invest in manufacturing lines. It's just great. And the reason why this is so important is that when we've got a safe and effective vaccine, it will be necessary to make sure that everybody gets a chance to have it as soon as it passes all the necessary tests. So really, thank you to everybody who was involved in making that decision.
Dr. Nabarro, there's also a series of tests which are going to be taking place at the All India Institute of Medical Sciences on another Indian vaccine candidate. Are you hearing anything about this and the progress they've made thus far?
So I heard about this other candidate, but I don't know the progress. I do have in my system quite a nice dashboard that shows the state of progress of more than 100 vaccine candidates around the world. And it is another good example of international collaboration. We're able to actually see which ones are moving forward. And as I look at it, I think, first of all, how good that so many different countries around the world are involved in these activities and that there are many great partnerships. And secondly, that we've got quite a good pipeline underway. Again, thanks to our Indian colleagues for doing this. And once again, a gratitude and appreciation for the quality of Indian work in the development of vaccines over the years.
Dr. Nabarro, there's been a lot of research of late on the aerosol threat posed by Covaxin, posed by COVID-19 in the air, how people can pick it up just because it loiters in the air, it lingers in the air. So could you share something more with us? We all wear masks to protect ourselves. Are we still in some sort of danger because it lingers in the air for longer than we thought it did?
You know, as we learn more about this virus, we also find some quite disquieting pieces of information. As I understand it, and I'll share this as frankly as I can with your viewers, the main route of transmission of this virus is from a person who's got the infection, having a really unpleasant irritation in the upper part of their respiratory tract. And then when they cough, they then project droplets, usually up to a distance of 1 meter, exceptionally up to a distance of 1.5 meters. And it's these droplets which contain virus that are the really unpleasant infectious elements. Now, there are certain circumstances under which, as well as having quite large droplets, smaller particles are also produced when we cough, or when we shout, or when we sing. And these smaller particles, what's called nanoparticles, do seem to be able, under some circumstances, to be picked up by the wind or by air currents and taken further than the 2 meters. That's called aerosol spread, or as you just said, airborne spread. And the big question is, how important is it? There has been airborne spread confirmed when certain medical procedures are undertaken. That's when, for example, you've got a patient in an intensive care unit. There's a tube into their windpipe that's helping them breathe. You're taking the tube out because they're getting better. As you take the tube out, they cough like anything. It's a very dramatic cough. And the evidence suggests that these nano or micro droplets can come out then. You get aerosolization, and there's a real risk that transmission could be over a longer distance. Other similar examples have been cited in the literature. Choir practice in Washington State in the US of A. Also, some kind of cold stores where there's quite high air currents, and there's a suggestion that nanoparticles may be active there. But at the moment, we don't think this is the major means of transmission. It is a subsidiary means. We have to keep looking at it. But what does it mean in practice? Answer, it does mean that we have to look at the ventilation of confined areas and make sure that it's good. And secondly, it gives extra impetus to the wish that people wear proper face masks, because that, we believe, can have some protective impact on the airborne spread.
One final question.
Yes.
We've really stepped up our testing in India. We need to keep testing a lot more, but a large number of the tests are through the rapid antigen tests, and that's not the gold standard. The gold standard, as I understand it, are the RT-PCR tests. Yes. And some of the norms that we have in India, as defined by the Indian Council for Medical Research, basically say that if you test negative on a rapid antigen test but have symptoms, then you are told to go for an RT-PCR test. However, if you are asymptomatic while doing a rapid antigen test, you don't have to do an RT-PCR test. Is this not problematic? Because there could be a situation when there are asymptomatic people who have no symptoms, who seem to be cleared on a rapid antigen test, being allowed to walk around.
Yes. Well, thank you very much for raising this point. Each nation has to develop their own strategy for testing. And the reason for that is that the, as you say, gold standard test, reverse transcriptase polymerase chain reaction, or RT-PCR, this gold standard is quite hard to scale up and roll out in very large numbers. I mean, India has done remarkably, if you don't mind me saying so, given the size of the country and the complexity of enabling people to access tests. But it'd be great if there could be more testing available. As you say, the rapid antigen test is a quick test that can give you some clues as to what's going on. And I think by preference, one would hope that everybody who's been considered needing a rapid antigen test could, if necessary, have the PCR test. But if supplies are short, then you have to make some selective criteria. My suggestion to people is that we are careful about asymptomatic COVID transmission. We don't know the full extent of how many people can actually transmit this virus without having symptoms. We know that some people can transmit before they go on and develop their COVID symptoms, before they get their fever, before they get their cough, but in a day or two. So there is a case, I think, for needing to be careful about asymptomatic transmission. But I have every sympathy with government, whether it's national government or more local government, having to establish some criteria, because not everybody who is deemed to need it can access an RT-PCR. So let's keep an eye on the asymptomatics, but for the time being, I think that the strategy being proposed makes sense from where I sit.
Dr. David Nabarro, it's been a pleasure speaking to you as always. Thank you very much for being candid with us, sharing your views on where we stand as far as finding a vaccine is concerned and the precautions that we need to take in the meanwhile. Thank you very much.
Can I just, if you can keep the tape running for a second, just real appreciation of everybody in India, people, local government, national government, non-governmental organisations, health workers, all those who are involved in care, contact tracing. It's an enormous, enormous task you're doing. And as I watch from afar, I am just so proud. Thank you very much indeed.
Thank you, sir. Thanks very much.